Eva, good morning, everybody. Hopefully you can hear us okay. If you can't, just let us know through the comment or chat. So welcome again to the AI Forum, our bi-weekly community building effort to engage people interested in AI or doing AI here on campus or around the country, actually. So today we're very excited. I'll let Rishma give the full introduction to our guest speaker. But I just have to say and plug that I've known Michael for a long time, and he's just fantastic. So we're really excited he's here today. This is an effort run by the Center for Collaborative AI in Healthcare. Yuan Lo, Dr. Lo is here, and he's been leading this charge around the AI Forum. And this is an effort sponsored through the Institute for AI and Medicine. So with that, I'm going to hand it over to Rishma to introduce our speaker.
Thank you, Dr. Ko. So today's session, we have a phenomenal speaker. Our subject today is going to be bridging the gap, transforming AI concepts into practical solutions for outpatient physicians. And a little about our speaker today. A frontline physician turned entrepreneur, Dr. Michael Fang, is on a mission to ensure that high-quality healthcare is not only more affordable, but also accessible to all. As the co-founder and CEO of Base 10, Dr. Fang designed and launched an infection control clinical decision support (CDS) software system. This innovative solution was utilized by nursing homes during the pandemic, evaluating over 1.5 million patients and resulting in a remarkable 30% reduction in infection mortality compared to other facilities in the same region. Subsequently, the system gained FDA approval as a Level 1 medical device data system, setting a new standard in infection control. Dr. Fang also co-founded Imosphere and developed an innovative social determinants of health platform that currently monitors over 7 million mental health patients across the UK, Ireland, and Scotland to assist the UK's National Health Services in predicting annual care costs. Dr. Fang graduated from Northwestern University's Feinberg School of Medicine and furthered his training in internal medicine and geriatric medicine at the Medical College of Wisconsin. Throughout his career, Dr. Fang has served in various capacities, from geriatrician and medical director of informatics for Indiana University to private practice. He is currently the COO of WeCare, an independent practice association comprising over 120 practices. Here, he is spearheading the development of an automation and AI-driven technology infrastructure to support the network's planned expansion to 1,000 practices in the next 2 years, underscoring his ongoing dedication to advancing healthcare accessibility and affordability. Please help me welcome Dr. Fang.
Hi, guys. All right. Thank you. And I want to keep this really dynamic. So thank you for you guys who made it through the bad weather to come here. If you're here, you're being rewarded with donuts. Those of you on Zoom, you're missing out, man. But let's get the chats going. I really want this to be where you guys are commenting the chats. Don't worry about what you comment. If you don't like what I'm saying, I want to hear about it. I want to see it because that's the way we can make this more exciting. Okay. So as you can call me Michael. Yes, I'm Dr. Fang. But what I really want to give you guys is a talk today about the perspective of how to get what you guys are doing in terms of creating all these AI algorithms and technologies and what you really have to think about when you're trying to get it to the front lines, right? Because at the end of the day, just like a drug, a molecule is a drug, but to get it to an actual form that you can give to patients at scale, right, or can be priced and paid for by insurance is a whole different step. So there's that gap that I want to help you guys understand and hopefully give you a little bit of insights as you progress in your career. Okay, so how do we make AI reality? So I'm going to talk about like 3 really basic concepts, okay? We're going to talk about picking the right problem, and I'll talk about how picking the right problem is really the key because a lot of times, people have a solution and then they try to find the problem to fit the solution, right? You hear the adage of if you're a hammer, everything's a nail. Yes, right? So don't look for, do you have a problem with nailing things down though? Right, that's something we're gonna talk about. I'm gonna talk a little bit and go on a little bit on the ethical side and say, hey, you need to protect the use case of your AI, and I'll give some examples of what happens when you don't. And I'm gonna give a little bit of business and say, hey, look, at some point in time, you're gonna need to, get this finance, whether it's grants or you got investors or a partnership with some corporation. Money's good, but too much is a problem. All right, and I'll show you again what that means. All right, with that, let's talk about designing your AI product. Okay, so the key to designing a good AI product is selecting the right problem, right? So like I said, you don't want to be, you don't want to say I have a particular solution. That's like saying I'm a I'm a cardiologist, so every chest pain is cardiology related, right? If I'm a psychiatrist and every chest pain is, stress or manifestation of our mental health well-being, right? Like you end up pigeonholing yourself in that. So don't start with what you have. Start with what's the problem that you want to solve. So what is the right problem? Okay, so here's 5 things that I want you guys to remember. All right, so the right problem for AI to solve in the real world sense of practicality would be where the problem has a human bottleneck issue. Now, that could be in a couple of different forms. It could be that it takes a long time for a human person to gain all the knowledge of a to become the subject matter expert, right? And stay the subject matter expert. Or it's where you need a human person to execute on that knowledge, right? To take the next action item. And because there's only so many times in the day and they're a human being, they need to sleep, that becomes limited. So it's not 24/7. Those are the kind of problems that in reality are what needs to be solved. Okay, so what about the next thing? Well, you also want to make sure that the problem has somewhat well-defined data sets. I've been to a couple of the IM talks, very, very awesome talks, where there's a lot of researchers among you who are trying to take data, right? And you're taking thousands upon thousands of data points and you're trying to figure out which one of those matter. That's cool. That's what you need to do right now in the R&D phase. However, when you're trying to build a product, you don't want to have all variables be a part of the equation. You want to actually try to restrict that down to a well-defined set of data that you can actually teach the AI on, right? The other thing is you also don't want the AI product to try to do everything and everything at once, right? Trying to make an AI doctor is very, very hard. Trying to make an AI person that knows when to order a PCR test is much easier, right? So you want to have a defined set of desired outcomes from what your algorithm would do. And then you get to the solution, right? And that's where you say, okay, and is there an applicable AI technology that we can use to solve this particular problem? Is it something like a OpenAI where we need something a language model to be able to read something and understand it, or is it in a automation aspect, or is it an AI that can mimic a human workflow? Like, what do we have that we can put together as the technology stack to solve the problem? And the 5th part is it should get better as you scale. Meaning it shouldn't be a model or shouldn't be a product where as you try to go to the next clinic or the next scenario or the next disease, it actually becomes harder. It should actually get easier, okay? I'll give you guys some examples so that this concept can be a little bit easier to understand. So let's talk about, so as mentioned earlier, thank you for the great introduction, Rishma. So I am currently the Chief Operating Officer of WeCare. It's an independent practice association. So these are private practice doctors who band together, right? Because they're all basically solopreneurs, but they want to be able to get better insurance contracts. Maybe they can get better support with each other. Maybe they can share some of the costs of their practice, right? So it's a very real thing. Some of you guys, many of you guys may end up in private practice or in the private care setting, right? So this is an area that I would love for you to hear a little bit about. So in the private practice setting, there's not the support of a lot of people. It's just you, your partner. If you're a big group, maybe there's like 20 of you, and that's pretty large as a medical group. If there's 20 doctors in the group, that's considered large. Most companies have like 200 people, right? So 20 doctors in the group is quite small. But in that sense, because you are a small business, you don't have the staff to do a lot of things, right? So as I'm trying to help the physicians of our IPA, I'm trying to figure out like what can I do to offset their burden, all right? This first example isn't medical, but hopefully help illustrates what we're talking about. So this is a company called 8AI, all right? And if you're in private practice, one of the biggest things you have to do as a doctor is you have to every year decide which insurance contract you're going to sign up with, right? So are you going to sign up with Blue Cross Blue Shield? Are you going to go with Humana? Are you going to go with this ACO? Those contracts are extremely long and very hard to read, especially if you didn't go to school to read legal contracts, right? So what you're trying to do is understand maybe 20 of these contracts in one go, and you're trying to figure out at the same time, like which one of these contracts, if I sign up for, would help my practice make more money, right? And it's not simply like, oh, they pay $2 here and they pay $5 here, so therefore, it's not that. There's also, what is your patient payer mix? Are you Medicare, Medicaid? Are you elderly? Are you family practice? Are you specialty, right? So there's a lot of knowledge base that has to go into that, and most physicians don't really read it very well. The other thing too is that once they decide to participate in an insurance company, you also have to get them approved by that insurance company, right? So there's a whole entire workflow before you even get to seeing patients. You have to figure out how you can get paid, all right? So this is what AI does, right? So we said, all right, well, let's take a look at the problem. Is it a human restricted problem? Yes, it is, because it usually takes a very knowledgeable office manager or someone who's done the last 5 years of their career reading these contracts to be able to explain each contract to a physician in a way that they understand. And of course, it's time limited because I'm trying to have that conversation one-on-one with 120 doctors on, right? 120 doctors times 10 contracts is 240 conversations. That's very hard to do, right? So that is a human restricted problem. Great, that's number one. That checks off. So what about the data set? Is there a certain amount of data that we can extract to automate this? And the answer is yes. All the information you need is in two different sources. One, the insurance contracts themselves, which is a Word document. The other one is CAQH, which is a database that doctors usually have to fill out in your private practice that tells them about your patient mix ratio. So you actually do know what their patient population is like, right? Okay, third, what is the desired outcome? Are we trying to do 10 things or are we just trying to do one thing? Really, we're just trying to do one thing, maybe 1.5 things, right? Like the first thing is help these doctors understand which contracts would help them get paid better based on their patient ratio and which one they should sign up for. That's it, one, okay? So is there, and step number 4, are there applicable AI technologies that we can piece together to solve this problem? And the answer is yes, right? So yeah, there are AIs that can read language models that you can train, just like a human person who's reading these contracts, but even quicker, like within a week, we could train it to read 5,000 of these contracts, and it would actually know how to interpret these and be able to present to a doctor in a chat format, right? So we have a chat bot that the doctor literally says, okay, of these 9 contracts, which one would help me make more money with elderly patients? It will tell you. How much do I make? Based on your CAQH data of your patient mix population, you'll probably make an extra $200,000 this year. Nice and simple, right? Do you want to sign up? Yes. And now we take all their data and go and approve it with the insurance company, right? So that's the ideal situation. And then number 5, is it scalable? Absolutely, right? So as we add more contracts, the AI gets smarter. As we expand more clinics, it sees more, and right? So this kind of feedback loop will help AI be able to service not just our IPA, but the 400,000 private practices throughout the country. All right, I love the chat going on. Okay, keep them coming. All right, guys. If you're confused about what I'm saying or the use case, or you think the technology is not that cool, that's cool. Say it. All right, next one, Red Sky. Another one that is not pure medical. I understand I'm giving 2 examples that are around the business of healthcare, but please understand you're professionals in the business of healthcare, so you need to understand the business. All right, so what's the other problem that we have with private doctors? And they tell you, right? They're like, we get denied by insurance companies all the time. I did the work. And then I submit my bill, and then they tell me that it's the wrong code, or like my documentation is not consistent with the code, or they're going to pay me less than that. Now, what happens typically is you have another human person, right? So let's go through the same 5 steps. Is it a human restricted problem? Yes, it takes a human person to review what the insurance companies are sending back as denials to understand what is the reason for the denial or the underpayment, right? Takes time, takes to learn all that, and takes time to triage it. And then what do you have to do as a human person is go back into the doctor's EHR and try to gather the data to basically fight the claim, right? To say like, no, actually I did do this exam. Actually, I did order this test. We did review these things, right? And try to resubmit that. So all that takes time. All right, well, okay, human restricted problem. So the second thing is there a limited set of data that we need to deal with? The answer is actually really simple on that one. The insurance companies always send back their denials in 2 formats, 835 and 837. Again, PDFs, right? And they put on there why they're denying you or why they're underpaying you, all right? And as I said earlier, the answer to all those questions may be in the doctor's notes, okay? So only 2 sources. We're not talking about like thousands of sources of different types of data. What about our outcome? What do we want out of it? Well, we want to very quickly understand the reason for the denial. We want to gather the missing data, and we want to resubmit that as quickly as we can back to the insurance company, okay? Is there AI technologies that we can leverage on this? Yes, there is, right? So similarly, there's we'll again leverage AI technologies that help read unstructured data, like doctor's notes, to extract things, but we also needed to layer on an AI algorithm that mimics, right, as the human person, it's a human guided AI learning, right? So as the human person is saying, I'm reading this, I'm looking at this sentence, I'm finding these paragraphs from the notes to resubmit back, the AI is looking at all that and saying, okay, then the next time when I see a similar denial language, I need to go into doctor's notes and look for paragraphs that may look like this and include it in our resubmission form. Very simple. It doesn't really know why, but it just go, well, I just know that every time the human biller goes and do this, they're looking for these particular type of sentences and language. Okay, so that's what we did, right? And so Red Sky Health is the company that's helping us with that. We didn't build this from the ground up. We're a private practice, so we don't build technologies, right? But Red Sky Health did this, and they're now automating 85% of our denials within the hour. Okay, within the hour. Traditional billing companies would be like, okay, well, we got denied and it's going to take us 3 months. It's like within the hour, as soon as the insurance company comes back, we're like, resubmit. 85% is going right back out. So most of our practices are now gaining additional revenue of another $250,000, sometimes to $1 million per 3 months, right? Because they're not having to wait for that process to happen. And here's the cool part. Well, I should say it very carefully. It's not cool. It's actually kind of annoying. But if you're an insurance company, your policies vary state by state, right? So we've heard this from private practice docs where they say, well, my billing company got, right, the human person got really good at learning all the tricks of this payer in New Jersey. And then I decide to cross the border and go start a practice in New York. And all of a sudden, it's a whole different set of rules that they made up in these 835 and 837 claims. And now my biller has to learn that. Again, we go back to that problem number one, I have to learn it again. But the AI doesn't care, right? Like you just have to show it a few times and it starts to get better and better at learning these tricks. So now what Red Sky is doing for us is ahead of us even submitting a bill, it's looking at the physician's document saying, we know this insurance company in New Jersey is probably going to send you a denial letter just based on that. You may want to change it ahead of time. So we're trying to now even proactively minimize the number of denial claims coming back, okay? Sorry if this is all talking about money, so let's talk a little bit about medical stuff. All right. So yes, one of my companies was Base10. I'm really proud of this. So this was in 2017 before, you know, ChatGPT and all this other stuff came out. And I'm not a technologist, guys. I am pure physician. You know, went through med school. I'm cell molecular biology. I didn't do informatics, like, right? So I'm not a coder. I don't even have an MBA, right? So I didn't have time to do any of that. But at that time, I was like, okay, well, look, if Google Maps can help you navigate the streets of a city without you pre-memorizing a map ahead of time, why is it that providers, physicians have to memorize disease maps, so to speak, right? All these protocols and workflows before we see a patient. And what if I forget? Well, then you're gonna get lost. What if you didn't recognize the map, right? You're gonna be wrong. So why can't we have something similar like Google Maps for clinical decision support? Right. And at that time, the company was actually called Base10 Genetics because one of my worst subjects was genetic testing because I didn't learn it. I had 1 month of it in med school. Right. So with all these different genetic diseases coming out and all these different diagnostics that you can do in advance, I was like, I don't even know which one to order. So I started putting together the concept of a tech that would be able to ingest patient data. And then your point A, let's use the Google Map analogy. Your point A is you as a physician or clinician saying, based on these symptoms, I'm worried about point B, which is whatever the differential diagnosis is. Okay, so if I have these symptoms, I want to worry about Huntington's. I have these symptoms, I want to worry about Parkinson's. Then the software would say, okay, then based on that information, here's the test you should do, right? Here's the prophylactic treatment if you're thinking about it, and so on and so forth. So interestingly, we launched this platform at the end of 2019, around October. 3 months later, nobody cared about genetic testing because it was COVID time, right? Everything was about COVID. But it was cool because the tech was there. So we said, well, what's to stop us from bringing in whatever new information was being released by the CDC or any other research organizations about this virus, right? So we did that. And what happened was this software ended up being used, I'll just jump ahead a little bit. This software ended up being in about 140 nursing homes. And before we went in there, they were trying to assess, there was like teams of doctors and nurse practitioners in every nursing home trying to triage infection cases, right? So in 140 nursing homes, we tallied it was about like a team of 80 physicians and nurse practitioners trying to keep up with infection assessment. And remember, it wasn't just COVID. We still had the typical nursing home stuff of bed infections and pneumonias and flu and all that stuff, right? So it was 80 full-time practitioners trying to deal with this. 60 days after we installed our software in these 150 nursing homes, it was 2 nurse practitioners in front of a laptop managing 40,000 cases of evaluation per month, all right? And it was good, meaning that the amount of time spent was much less. All 140 nursing homes, it didn't matter if you were a nursing home in Seattle, Washington, or in Tennessee, and Kentucky, or Florida, you had 30% less mortality during the 18 months on our platform during the pandemic than any other nursing homes in the state, right? So it wasn't like geographically restricted. It was software that was helping with the clinical decision support. And yes, that's where we ended up getting an FDA approval for software as a medical device. I don't know if you ever heard of that. I didn't prior to that. I just thought, I was like, medical device, software, right? But then they were like, no, actually, there's a category where you can be software as a medical device if you're repeatable, precise, and replicatable, right? So we got that. And you'll know that I'm not an academician, right? My friends would laugh if they ever thought I would ever actually publish anything because I never did any research, quite frankly. But I ended up co-authoring a paper with the CDC on the vaccine effectiveness because we were the only platform that was capturing enough of the data as well as a clinical decision process that can let the CDC see that, well, if we gave a vaccine, did it work? Because this was the early day of the pandemic where, if you guys remember, there was a lot of political, moral debate about the vaccine, and they needed to show that the vaccine was effective. And they literally went to all the EHR companies, bought data, and couldn't see it anyway. And the only way they did this was through our platform. So we ended up co-authoring a publication with them. Okay. All right. So let's talk about the next subject, right? Where we say stay true to your use case. So your AI is not evil, but your end product may end up being. So as you're thinking about like how you're going to productize, you have to understand like the algorithm works. But if you're going to make sure that your AI technology is used in the right way, you actually, with your team, have to stay on top of that. So I'm going to give 2 examples, right? Very similar company, Imosphere. Full disclosure, yes, that was also one of the companies I founded, right? So we designed a platform that captures social determinants of health data. We did this back in 2013 before the word social determinants of health was even the thing. We just called it social history, right? But as a geriatrician, I was like, hey, look, I can tell you if my old person at home can't get out of the house to get food, we will see her back at the hospital because of that, and not because I didn't manage her heart failure or dementia correctly, right? So we were starting to capture that information, and this platform ended up not being used by the United States. It ended up being used by UK, by the NHS, which is their equivalent of CMS, right? To capture data on patients who are at home for mental health disorders. And then they use that information to budget. So NHS is actually using our platform to budget patient by patient how much money they need to give to help them with not just medication and medical care, but also maybe food. Do they need a ramp built? Do they need someone to pick them up? Do they need, a caretaker to come and help them clean their house? They actually can get down to that level of budgeting, right? Now, let's talk about the similar technology, right? So Navi Health, I actually like that company, but they had designed a very similar formula, which was then used by United Healthcare. It was supposed to help look at elderly people and predict their post-acute. So when you're about to send them home from the hospital, what would be their potential care needs? Now, allegedly, they got sued because allegedly they weren't using that algorithm to help budget for that. They were using it to deny care, okay? And then eventually, United Healthcare dropped that entire, they dropped the branding around Navi Health, but to this day, they're still using that algorithm in the background. For what? We have no idea. All I can tell you is that when physicians and patients ask them for the report from their algorithm to say, how did your algorithm work? What did it say? They will not share it, okay? So imagine if you were the designer of the AI algorithm behind Imosphere, you feel pretty good, right? But if you're on the other side, you might be questioning like, what have you done, right? To the healthcare system, okay? All right, let's talk a little bit about don't raise too much money. I understand most of you are very young and you're in research, and this is Northwestern. So I remember when I was here as a student, right? We don't talk about money that much, but I also feel like what was really awesome seeing this IAM forum happen was we also didn't talk about technology back in our days either, right? And I really appreciate you guys actually taking a step in doing that, because you do need to know all the tools and all the things that affect your profession, okay? So I want to give some examples. So these are, you can Google them, but Olive, Babylon, Mindstrong, look at the numbers, right? And by the way, if you looked at their founders, some of them are clinicians, most of them weren't, but they all had very aspirational and good intent when they founded their original company. And the AI they originally created did do the things that they were trying to do, okay? But what happened was, at some point, they started attracting investors, right? And they got massive valuations, like billions of dollars of valuation. So you would wonder, like, so how do you go from like a $4 billion valuation like Olive, raising $1 billion and being dead in 2 years? How do you go from being like Babylon, where you went public at $2 billion valuation and die in 2 years? How do you go from being Mindstrong, which is mental health, raise $160 million in 3 years, which is probably more money than most of you guys have seen with grants, right? And then shut down, like literally, like again, 2-3 years after that? The problem is you lose focus, right? So remember I said that you got to protect your use case. A lot of times what happens when you get too much funding, even you as the creator of the technology, you start to think of all these different use cases. And that's why I keep saying, like, hey, stay to those 5 steps, right? If you start to think of too many, like my AI can process all these data sets too, that may not be true. It can do all these particular types of outcomes and outputs. That may not be true, right? It's totally scalable once we go to a different adjacent market. That may not be true. So you have to really slow down and look at that. Even if you have money, money just allows you to explore that better, but you shouldn't automatically go do it. And every one of these companies made that mistake. And that's why they did not survive. And it's too bad, because their AI tech was good. I liked what they did, but now it's gone, right? It's sad, but Babylon didn't, like, their AI tech didn't even get bought. When they went bankrupt, their telemedicine platform got bought. And I'm just like, well, dude, that's just Zoom, right? Like that was what got bought. It's like, okay, right? So that's why I want to make sure that as you guys are working through designing your thesis and your research, right, to start thinking a little bit ahead and understand how you can build a better product. Okay, so some unsolicited career advice, because you haven't been 46, I've been 20 something. So that's just some unsolicited advice. I really want you guys to expand your curiosity. And what I mean by that is, right now you are in a learning environment. So yes, awesome. You are going to be very curious about how to design the models, the data, and that's cool. That will naturally happen. What I want you to get curious about is hopefully some of these other things I'm talking about. Like, what about the business of my profession? Who are the players in my industry, right? Like, yes, we all knew there's insurance companies, but do you really know how they operate, right? Okay, so my algorithm can really help find the next clinical molecule that can be turned into a drug. Do you really know how pharmas operate? How they make business decisions, how they're funded, right? How they're regulated? Because if you don't, your product may not make it into their hands, right? So I want you to expand your curiosity beyond just what you're actually doing on the day-to-day. That's what's going to make you the expert, but learn more, right, beyond that, okay? I also want to encourage you to own your profession, right? This is one of the reasons where I struggle, because Abel was actually asking me, like, oh, are you in clinical practice anymore? In 2020, I had to put a pause on that because my software company was taking off, but I'm actually going back and launching a new dementia clinic with a couple of friends of mine, because now I feel I can do an even better job, right, as a geriatrician with a dementia clinic using technology to triage thousands more people, right? I'm a geriatrician, and I couldn't have seen 1.5 million patients for infections during the COVID pandemic, but my software did, right? And by the way, like, I was really bad on the boards with infectious disease. That was like my worst score, right? But that's the point. It's like our healthcare system, our patients shouldn't be limited to what we are not able to do, right? So I'm not good at infectious disease doesn't mean my patients should suffer because of my lack of knowledge, right? We should be able to leverage technology to do that. But own your profession. I want you to be, I love seeing doctors going and becoming leaders of, even if they're fighting for policies on Capitol Hill, right? I love it if they're part of FDA. I love it if they're part of CDC. I love it if you're part of local public health. If you're part of tech. Like, I think we need more clinicians and researchers at the forefront of that. Because if you don't own your profession, somebody else will, and then they will tell you what to do. Okay, and they don't understand what you do. They don't touch patients. They don't even touch the research or even put together the data models, right? So they're not going to really know how to use your product. So you being in that position is better. But still, stay true to your calling. Whatever called you into healthcare, whether it's wanting to help somebody or just take care of disease or make the world a better place, right? Stay true to that. And I tell people that myself too. Like 13 years ago, when I just graduated, my core was I want to care for seniors. I want to take care of the generation that was ahead of us that took care of us. That's my core. How I do that is by seeing patients and helping them manage their diseases. What am I? I was a geriatrician. Today, that hasn't changed. At the core, I want to help seniors who are the generation that's come before us, and I want to take care of them, right? How I do that is by creating scalable technologies that takes what I know as a geriatrician and what others know as a geriatrician and make it more democratized. What am I today? Well, today I'm sort of a technologist, right? So even though I keep saying like I really don't like being grouped that way, I still see myself as a physician, but that's what I do. So if you stay true to your calling, no matter what you end up doing, whether you are in clinical practice, whether you're teaching others, whether you are creating new technology, you're going to do great. All right. So lastly, I'll just leave, again, just go back to think about the practicality of your creations, right? Bill Gates said it, I love what he says, that great creations solve real problems. They don't just merely entertain. That's what we need to do, right? We need to quickly help you guys evolve, but go beyond saying, okay, I want to do this because I want to get a grant, or I want to have a poster, or I want to be able to present on stage. That's cool. That is what you're supposed to do right now as a student. However, we want to prepare you and help you look a couple years in advance and start thinking about when you leave, how can you become a real contributor of your innovation to fixing our very broken healthcare system. My contact information is on there. It's very easy to remember. It's Mike Fang MD, and it's mikefangmd@gmail.com. If you have any questions, I always welcome a conversation. Thank you, guys.
Q&A.
Q&A. So I have a room that wants to ask a question. Yes.
Yeah.
So what I really like, Michael, about what you're telling us, and so I spend a lot of time looking at innovations, and I think of innovation as not necessarily like this amazing idea that someone has, more so like, hey, I have a great idea and you have a great idea, and if we like combine those things together, how do we actually make it work? And that's actually real innovation. It's not like, there's not that many Einsteins in the world. Most of us are doing innovation by throwing together these things, and it's like that intersection of practicality and like a cool idea.
Yep. Yep.
Any?
Yeah, Michael, thank you very much for the great talk. Have a great presentation. I was especially interested in when you were talking about your company Base 10 and when you brought that out to the nursing homes. So I think there are so many great ideas and technologies out there, but sometimes it feels difficult to convince people actually using them. And I see, so there are two parts of the question. One is the technical integration. How did you manage to integrate the technology or software in their workflow, in their technical workflow? And the second part would be, how did you convince the people personally to use the software and prioritize that in comparison to others?
Great. Thank you so much for that question. So for those who may not have heard it, so the question was, as you're bringing your technology out there, how did you deal with the integration, right, into those particular settings? And the second part of the question was, how do you convince people of that? Let me try to be specific because I don't want to get too philosophical on this discussion. So if you're talking about integration, so that has to be part of your product design, right? So remember when I said part 2 was like know where your data sets are. So because I'm a geriatrician, I do work in nursing home, I know they only live off of their EHR, as most physicians do these days, right? It is what it is. So EHR most likely will be a big bucket of information you need, but the key was understanding like what information you need on it, because it's a gigantic mess of data in there, right? So for us, this is where having that clinical knowledge or that working knowledge as someone, if you're, I understand your PhD, right? So if you have a physician, like if you partner with me, I would tell you like, oh, this is the kind of information we need out of this data set, right? So when we were integrating, we weren't trying to go to the EHR companies and saying, give us access to all of your data, because they would told us no anyway, right? And they don't actually have their database built so well that they can actually give you all that data set. Most of it they can't even touch. They're like, it's kind of stuck here in this PDF, so good luck, right? But understanding, working with someone who understands the problem you need to solve allows you to understand the data set, which makes your integration work much, much more strategized, okay? That's number one. As far as convincing people, well, it takes a lot of charm, but it also takes a lot of it also takes understanding the right issue, right? So if you understand step number 1, I knew the nursing homes were going to get flogged, right? Once COVID happened, we were getting flogged by infection before COVID happened, right? I don't know if you knew, the stats were like, there's like 350,000 death of infection in nursing homes per year before the COVID. All right. So we were dealing with infection as a problem to begin with, right? So knowing that was the key to say, all right, and now I have a technology that can help you remove that barrier. And one thing I'll let you know, but what's cool about AI is the better products I've seen working out there is the product that you don't see, right? That you don't have to actually interact with, so to speak. So for example, looking at some of the examples I gave you, right? Like Red Sky, they're just automating denial claim processing. They don't really need the doctor or the office manager to look at anything. That's great. That's what I want, right? Same thing with base 10. When we're doing it, well, it's clinical decision support, so we couldn't, FDA would not have liked it if we said the AI was making decisions on what to order and who was infected, right? So we needed a human person. But what we did was we did a lot of user design strategy where we said, okay, this is going to be a toggle button. We're going to integrate it with Google Chrome, actually. So it's just when you log into your EHR, you just click the base 10 little icon and it turns on. It's almost like Grammarly, right? You guys use Grammarly or some other grammar checking software. It's just constantly watching what you're doing on screen and telling you if you're typing a wrong grammar or punctuation mark. Same thing. So we did that where the human is just working and then it would just pop up and say, this patient chart you're in, there are these symptoms in the last 24 hours. Are you concerned about infection? Yes. What would you like to rule out? Of course, COVID, right? Plus whatever else. Here are the tests you should order. Done, right? Would you like a treatment? Yes. Okay. And then they pulled in the data to say, okay, well, this is an elderly patient. So here's their allergies. Here's your last antibiotic profile, right? If we had a culture, and here's your renal and liver clearance. So your doses, your best antibiotic selection should probably be Bactrim, actually. And if you order a test, it comes back and the software will grab the test results and then change the recommendation right away, right? So usability is very important. For those of you guys who are PhDs, right, you guys are the brains behind designing these. This is where I really encourage you to partner with the frontline clinicians, even the nurses, because they'll tell you right away if what you're proposing for them to use or your intended proposal of how they would use your product is counterintuitive or takes up too much time, they will let you know in a split second. Probably not nicely, but that's okay. That's feedback, right? But that's what you want. And you want that early on because you don't want to be out there having raised money and now you're forcing a technology through and nobody wants to use it, right? So, but yeah, we were lucky because yes, it was nursing home. I've been working in the nursing home for like freaking 25 years. I knew what the product needed to look like. I was basically designing it for myself, right? So it just kind of worked that way. Yes, sir.
Great presentation, and your description of how the software kind of listens in or observes what's going on and then gives additional helpful guidance only when appropriate and doesn't interrupt otherwise is reminiscent of another company in the past. I don't know if you happen to have heard of MedCPU.
I may have, yeah.
A number of years ago.
Yeah.
So they used Microsoft's accessibility engine, some others, to actually read the notes as they were being generated in charts. And then would look, especially they had OB material really thought out well, and they would look for if there's potential for shoulder dystocia and kind of how you're documenting and what to do next, and look for other sorts of events. The company ended up getting acquired at one point by UPMC and then kind of died. Didn't hear anything more about it, but I thought was so neat, so well done to integrate. So
Yeah.
part of, just another example of things that you kind of were
That's
doing
right.
before. So what are some of the ways to avoid that sort of end again? I know you hinted at some things there, but to detect some of the warning signs, how do you shift your focus, stay tuned to ensure that these great ideas don't get buried and lost?
Yeah. So this is where I'll answer it with more. It's more of a business execution, right? So, and I struggled with this talk where I want to really stay more to the technology and AI talk, but I've just seen the world littered with great technologies, right? Corpses of great technology companies that never ended up surviving. So when you're starting to get your technology out there as a product, please be very patient in finding the right partners and clients. And I've been there, like there, I've taken money from the wrong investors and yes, they have destroyed the technology, right? So you have to plan quite a bit. You have to network. And so actually that's probably the key to fixing that is we're all in a great academic institution, right, where we are meeting like-minded individuals. I actually do encourage you guys early on. One thing I would have done if I were, back in the days, I would have probably tried to go to other industry conferences. Okay, and those of you who are in the room who are very experienced will know that, right? If you go to medical conferences, you'll meet other doctors. If you go to the CES conference, the Consumer Electronics, conference, or South by Southwest, right, you'll meet a lot of technologists and venture capital people. And it's important for you to learn how to interact with them. Again, going back to my recommendation, like stay curious, right? Be curious about how your technology would be funded. Be curious how your technology looks from the eyes of regulators. You won't find those people by going to the same medical conferences. So just as you're coming to this particular talk, right? And this isn't a talk about diabetes or how to, right? It's not that, but it is very important for you to network outside of your profession to understand all the other players around that. And yes, then you find the right partner. So if you find the wrong venture capitalist or the wrong private equity firm or right funder, they'll take you down a different path. If you partner with the wrong type of client, I shouldn't say that. They're clients, right? So, but if they have a particular use case they want to go down, you might end up being dragged that way because now what are you going to do? They're your client. So now you have to evolve your technology in a way that you may not want to. So be very selective, right? Yes, sir. Yes.
Exceptional for using in hospitals because you don't need to go on you don't need to use ChatGPT, OpenAI, which is proprietary.
Yeah.
So there is I'm pretty sure
I
you
love
know
open
there are-
source. Yeah.
Yeah, so Mistral and like Falcon and so on. So you can deploy them. How do you convince the physicians to use it? Or like you don't need even to make big changes because it's as you would have the best physician ever. I mean, you don't need to send your samples to Mayo Clinic or whatever because you have it right away. Any physician can actually tap in the whole medical history in a second diagnose or get differential diagnosis. But how do you make them? I assume that you try to just give them a simple tool, never mind specialized, but just how do you approach that?
So, and I don't know if the audience can hear the question. So the question was around how do you convince physicians to use your tool? Is that correctly? Can you give me a little bit more specific, like they do though. Okay, no, yeah. 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 Okay. Yeah. Yeah. Yeah.
Convince people? How do you block that? How do you break that barrier?
Yeah. Sales is hard, guys. That's a sales question, right? Like sort of, but I love the questions like that because I don't love sales, but I had to learn it, right? Because yeah, even as a physician, you have to maybe not sell, but you have to convince your colleagues of the usability of the product. How do I answer this? So as with any technologies, if you guys read, there's a oh gosh, I'm forgetting the name of the book, but there's a nice little graph that was drawn one time that was about the gaps in between going from innovation to early adopter to early majority, late majority, crossing the chasm. There you go. That was the name of the book. You don't have to read it anymore because you can just ask ChatGPT to give you a freaking summary. Right. So basically, a lot of times what we're stuck in this particular environment, especially for Northwestern, right, where it's heavy R&D, right, a lot of intellectual property is being developed. You're at the early phase of what we call innovators. In the innovator phase, it's very easy to find fellow innovators who are susceptible to your ideas and so on and so forth. And that's where you might be able to get a couple of, if there was a physician, you might be able to get them to say, I will try this, right? The next phase is the early adopters, Early adopters are very tiny. If I say the innovators are 1%, early adopters are only 2% of the population. But early adopters is where you may have the likes of Northwestern as a hospital, or the ortho group that you finally got in touch with that says, hey, this is really interesting. We will try it, right? Because Northwestern wants to be at the forefront, right, of medicine. They want to be ahead of other people and trying new innovation. Same thing with Mayo, same thing with Cleveland Clinic. So they're going to do those things. Now, what happens though is most people think that the interaction or the value proposition of their product in those two groups are what everybody else wants. And that's not true, okay? That's not true. So I'll give you an example of iPhone, right? When the first iPhone came out, who bought them? Not you, me, like it was like celebrities. Why? Because they're the early adopters. There was a need to have that kind of swag, right? For the early majority, which is the rest of us, right? We would say, okay, well, this is now affordable, right? And I can actually buy it more easily from Apple and so on and so forth, right? And there's apps on here that I can use in my daily life. Great. And then there's late majority, which is my parents. They didn't care about that at all. The only reason they bought an iPhone eventually was because they can FaceTime their grandson, my kid, right? So that's an example of when you're progressing through the different market and you're trying to quote sell your AI technology to somebody, you have to understand the mentality and the needs of that market. So late majority market, which actually is medicine, right? Because we're not going to take a new drug and just give it to everybody, right? We have to know that this drug has been FDA approved, that it's paid for by the insurers, right? There's all these things have to be there for that technology to be given to patients. So it's the same thing with your AI tool. They have to know that this is safe. This has some cybersecurity behind it. Just look at what happened with Change Health, right? There's a way to reverse things, right? They want to have all this foolproof process before they buy as the late majority market. So most of the time when we're out there trying to quote promote our company's product, we might find a physician who himself is an early adopter or innovator, but he is part of this late majority market. And you need to understand the mentality and the things that need to be built around your company and your product, right? For the late majority market. Like going back to iPhone again, my dad didn't buy it because he said, there's no warranty behind this, right? And also I don't want to pay $1,000. So what did Apple eventually do? Oh, payments, right? So it's only like $30 per month for the next 5 years, right? On your phone. And yes, there's a warranty on it now. Oh, and you don't know how to use it. I don't want to call your hotline. Okay, well, there's the Genius desk. You can actually walk into our store. My dad walks into that store for like social reasons, just to bug Kenny, right? like just to mess with him, right? But like it's that is the ecosystem they had to set up for all the 60-plus-year-olds to actually move to a smart device, right? So so you have to understand your market that you're selling to. Yes, sorry.
We have a question here. How do you decide when it is time to design an AI model for a specific use case versus when it's time to broaden your horizon and scope to ensure longevity and scalability?
That's a very, very good question. So ask again, because it was so profound. I have to like re-listen to that again. So yeah, one more time.
How do you decide when it is time to design an AI model for a specific use case versus when it's time to broaden your horizon and scope to ensure longevity and scalability?
Okay, so I guess I just to make sure I clarify. So creating an AI model for a specific, that's like the first step you have to do, right? Like, so most of you will probably be doing that, and I recommend it. That's why I said those 5 steps. Try to keep your initial AI product to a very specific use case. You'll have a better chance of solving it, all right? So I don't think it's not either or, it's both and. It's like, it's a continuum, right? So that's where you would start first. I would say if you haven't figured out if your AI works for a specific use case, you probably shouldn't be thinking about broadening the scope. Probably shouldn't, right? Now, if it's failing that use case completely, you could say, well, where else can I use this technology? Maybe I'm solving the wrong problem. But remember what I said earlier, like don't look for a problem. Don't have a solution and try to find a problem that it will solve. Find a problem and then design a solution that will solve that problem. So be curious, right? Be the inventor. If you invented something and it didn't solve that problem, either you have to start from scratch and rebuild it again, or you can say, well, I guess I can't solve that problem. So let me find a different problem to solve, and be ready that whatever you did on the previous problem isn't applicable at all to the new one. Okay. just be ready for that. But if you can do that, I think you'll naturally know when you can scale out. But I think it's a continuum of your experience as an inventor. Yes, sir.
Can I ask you, sorry, can I
Oh,
ask you a
go ahead.
follow-up question to that?
Yeah, please.
You talked about how, when you're sending claims, they're likely to be rejected, or you may not get your reimbursement as easily as you would expect.
Yeah.
At what point do you recognize that it's important to be proactive with an AI solution versus getting involved in changing the very process that you are trying to challenge now, whether it's business or clinical practice?
So the question is, when do you know you need to change your technology versus the process?
Yes.
Okay, okay. And whoever asked that question, if I'm not answering correctly, please feel free to reach out to me because I'm trying to, you're asking great questions and I'm trying to make sure I'm understanding them correctly. So ideally, you never want to be the technology company that is trying to change a process because you will hit so many walls right away. It's not that the process shouldn't be changed. You may be right that the process should be changed, but there's a reason those processes exist, whatever inefficiencies or regulations are there. If you're trying to change that process right away, you're probably going to be swimming up against the stream a lot harder. So usually what I would say is make sure your technology solves the specific problem that you're trying to address, okay? When you really have solved that problem as a piece of the process, you now have the legitimacy and the reputation to say, okay, now I want to solve the adjacent process problem, right? And I don't know if it was the same person that asked about like for the billing information as an example. So they didn't start out, Red Sky didn't start out, and interesting, Red Sky didn't start a technology company. You know who founded Red Sky? It was the billing manager of a private practice. And he was getting really frustrated that his doctors were working so hard and they weren't getting paid. And he hired a company out of India to do the billing. But then, like he said, like they got good with billing in one state, and then the doctor said, "This is great. Let's go buy another practice and expand to Texas." And immediately, that billing company was useless because it was the same insurance company. We're like, we're still dealing with Blue Cross Blue Shield. How is it Blue Cross Blue Shield Texas have all these other reasons of denying the same procedure, right? So he built it out of the frustration, which actually that's most of the great startup I've seen. Is like they build something out of frustration, right? So in the building company, they started with just saying, let's solve and understand all this one payer's gaming in the state of blank. And then we're going to try to evolve the AI to the same payer, but in the state of Texas. Okay, now let's start to add in the data from other payers and see in the state of Texas, does Humana give a different reason for denying the procedure or the visit or whatever the case may be, right? So it's that kind of intentional design of increasing the scope of your technology that will help you be successful rather than just letting it, just jumping to it because you feel like this is not working, so let me try something else really fast, right? You have to design and be intentional in your expansion. Yes, sir.
Putting your geriatrician hat on and also your kind of business acumen hat, what are some of your thoughts of the most compelling areas in geriatrics where there are or the most specific or the problems that are most conducive to an AI solution to address in geriatric,
Yeah.
in general geriatric care?
Oh my gosh, there's so many. And I want to share it all because I want one of you guys to make it, please. If you do, I promise I will get you funded. So there's the subject matter expert, which we call SME problem, is huge in geriatric care, right? And I'm not talking about just in terms of what a physician knows to care for a patient. I'm talking about even knowing what are all the available resources for a particular patient who's in a particular state or county. There are funding that's local counties or states have to take care of these patients, but unless you're freaking reading the website every day, you won't know that exists. Okay, you won't know. So this is where the simple ability for an AI to read a website and tell you what's going on. Like I remember seeing this video, this high schooler made one, she just said, my high school website is terrible. Parents never find any information. So she just basically made an AI off of OpenAI, right? And read the website so parents can just ask like, when do we have parent days off, right? When is late school day? Like how much is the swim team fee? So they don't have to click through it and find it. Now take that concept and another company, I didn't feature them here, called ClearPoll. They're like, in nursing homes, they have to stay on top of these, regulations that can cause citations, right? You invite the surveyor and say, you screwed this up and I'm going to take away your license or you need to be shut down for the next 7 days. Someone has to read the state website all the time to say, okay, well, so a patient cannot be in bed for more than 17 hours, right? And we have to feed them at this time and like all this stuff. You can't keep up with that, right? So same concept, same AI, right? Where they had the AI read the website and then they comb through the patient chart to say, oh, this patient may be in violation of this F tag. They literally call it F tag, okay? Like F tag. All right, so there's F tag this, F tag that, F tag. But now the nursing home director can see like, oh wait, today I might get F'd on these 7 patients because I didn't realize like this happened in the last 3 days, right? So now they can be very proactive in getting that done. That's huge. And yes, those are patient care issues. Those F tags are not there for no reason. Because yes, at one point in time, nursing homes were pretty bad at taking care of patients. So we left them in bed and got bed sores. We forgot to feed them, right? We didn't document how much we feed them. So we said we fed them, but they didn't eat anything, right? So these are all things that are there for a reason. But now technology can be on the good side of helping nursing homes stay on top of that instead of a human person trying to read about it. And I tell you, because this happened all the time, there's usually only one human person that knows those rules. She goes on vacation for 10 days, and you cannot believe the number of F tags we have when they come back. Like when I was medical director of nursing homes, every time like Nancy needed to take a break, I was like, son of a, like we're like, just be ready for the surveyor to walk in and slap us, right? When she comes back from vacation, because like it was gonna be like happening. So I'm glad those technologies are happening. There's another company now that is helping with underserved population. Same thing, right? The AI is going out there and just combing the website for all these available community resources and organizations, and then stringing them together as a plan to say, if your mom lives in this zip code, there's this organization that can help with this. There's this church that may be able to help with this. There's this, right? And stringing it into just taking public information and stringing it into a plan. And then they can present to me as a doctor so I can say, yeah, the only thing I can do for this patient is when they come to my clinic. But now that I know all these other resources, I can present that to the family and say, hey, get in touch with this, follow this. And now this person can be taken care of, right? So there's all sorts of ways to use AI that isn't necessarily all around disease. By the way, I do love diseases though, because we really need help with that. But having said that, there's all these little problems around the care of medicine, right? The profession of caring for somebody that isn't pure medical that I think these AI technologies can make a big difference in.
There is Michael Johnson mentioned that his vote is for gait analysis for geriatric patients and
Okay.
the potential for the predictive value of AI to be able to predict falls.
Nice. Okay. Sorry, what was the question?
Question, it was just
Okay,
a comment.
good job. Great job, Mike.
Michael's like, do it.
Yeah, do it, man. So let me give you some, there's a lot of fall gait assessment risk out there. The ones I've seen, again, I do invite you to you're at Northwestern, you could probably find the geriatric department and say, can I go to the nursing home with you and shadow you through that? Because again, your algorithm probably works very, very well. The question is, how well is that data collected, right? Because that's always the problem. It's always, because I've seen fall algorithms out there where the EHR companies supposedly have that data too. So they're trying to come up with these fall assessment and things like that. But it's always like the completeness of the data, right? So going back to those 5 things I talked about, how big is your data set? Because if you have to gather a very big data set, right? If your equation, just simple math, if your math is like this long and all those little equations have, all those little factors have to be filled in before you can calculate something, then it's not gonna work, right? All it takes is one nurse to forget to document weight or gait or standing something, then all of a sudden your algorithm fails, right? So you have to take a look at your algorithm and say, how easy is it for in the daily work of a nurse or doctor taking care of the patient for that data to be captured? Because if they have to go out their way to capture that extra piece of data for you just so that your formula works, it's probably going to fail a lot. Okay, so think about that as you're going forward with that. But we would love to get rid of falls. I mean, at this point, I'm just like, can someone just make an exoskeleton robot just so nobody falls? Seriously, because I can't, right? They will fall at some point. You can predict it, but you might not be able to prevent it, right? Because again, in homes and nursing homes, there's not someone there to stop them. So they're going to fall. It's like, great, now what? It's like, the truck is coming and you're just going to stand there and get hit anyway, right? So I think I just want to do a time check, but yeah.
I think first of all, thank you, Michael. This was
Yeah,
fantastic.
great. Thanks,
Love the
guys. Appreciate it.
conversation. Really appreciate you and the work you've done.